have the privilege of having Dr. Silke Hetch, who is going to update us on the imaging of CNS round cell tumors. So let me introduce Dr. Hetch for you. Dr. Hetch received her veterinary degree in 1998 and a doctorate veterinary med in 2001, both from the Ludwig Maximilians University in Munich. Tried to do a little bit of accent there. Hopefully that came across and didn't upset anyone. She completed a residency in diagnostic imaging at Tufts University in 2005. She's a diplomat of the American College of Veterinary Radiology and the European College of Veterinary Diagnostic Imaging. Dr. Hetch has been with the University of Tennessee College of Veterinary Medicine since 2005 and is currently a professor of radiology there. She's also a consultant for VetCT, and her areas of interest include MRI, neuroimaging, and oncologic imaging. So perfectly positioned to give us an update on imaging of round cell tumors. So thanks very much, Silke, for coming on today. Really appreciate it. I'm going to hand over to you right now.
Thank you very much, Simon, for the very nice introduction, and thank you for inviting me to speak to the group. It's always an honor. So yes, I get to combine really my love for my three areas of interest with this presentation here. Imaging, of course, and then brain and spine and round cell tumors. And round cell tumors are fascinating to me. So as was said in the introduction, I work for the University of Tennessee, and I also am consultant for VetCT, if anybody considers that a conflict of interest. I do not. So what are we going to cover today? First, we're going to briefly give an overview. What are round cell tumors actually? It's a very kind of broad name. And then we are going to cover round cell tumors of the brain and round cell tumors of the spine. And I've rearranged this talk a couple of times because some of these tumor types can affect the brain or the spine or both. Others are more limited to one. So first I had it broken down by tumor types, but then it got confusing. So we are going to walk through the brain first and then the spine. So what are round cell tumors? The very first time I heard histiocytic sarcoma mentioned as a tumor type was when I was a veterinary student. And I distinctly remember that it was a surgeon, but he was specializing in surgical oncology, mentioning that these are the jokers of the tumor world. They can do whatever they want. Over the years, I've come to decide that other round cell tumors do that too. So all of these to me are the jokers of the tumor world because they really are not limited to just one type of behavior. So looking for some funny imitation or I should say image of round cell tumors, couldn't come up with anything too smart. But they're round, their cells are round. And based on textbooks, round cell tumors or tumors that are grouped under round cell tumors include histiocytic tumors, lymphoma, plasma cell tumors and multiple myeloma, mast cell tumors, melanocytic tumors, so our melanomas, and then also the transmissible venereal tumor. I put asterisks behind as in somewhat subjectively and based on available literature, how commonly we see these affecting the brain or spine, so the CNS. So histiocytic tumors, lymphoma fairly commonly, plasma cell tumors, multiple myeloma, and then rarely mast cell tumors and melanocytic tumors. And I have a funny story about this one here. You see that there's an asterisk in parentheses behind it. We'll talk about that. So round cell tumors of the brain, we are going to start with lymphoma, which is a very, very large tumor category. Obviously, it's the second most common intracranial neoplasm in cats, accounting, according to the literature, for 14% of cases. I find this rather interesting because I don't feel I've seen it a lot in cats in brains. Maybe I'm missing it all the time, but that's what the literature says. In dogs, lymphoma accounts for approximately 4% of primary and 12% of secondary intracranial neoplasms. And there's quite a bit of imaging literature on lymphoma. And this is a mixture of both brain and spine lymphoma papers. Some of them talk about both, some just one, and we will come back to some of them later with the spine discussion. But you can see that there's quite a few papers out there, including a very large one, which unfortunately doesn't really have imaging in it, this neuropathology paper that had as many as 92 cases. So what are some possible MRI findings when we image the brain in patients with lymphoma? Lymphoma can do whatever it wants. They can be ill-defined or well-defined lesions, single or multifocal, intra or extraaxial masses. Um, on MR, they're typically iso-intense to hypo-intense on T1. So is anything, really, if you think about it, most lesions are T1 iso to hypo-intense and hyperintense on T2. This is out of Will May's textbook. I did put an asterisk here because I feel sometimes I've seen them look more ISO intense, and in people, they can be hypo intense. So take this with a little bit of a grain of salt. But this is what the textbooks currently say. And of course, that doesn't really help because it looks just like any other brain lesion. What they do is exhibit moderate to strong contrast enhancement. And I would agree with that. It's true for a lot of the round cell tumors. These originate from outside the blood-brain barrier. They're not protected by the blood-brain barrier. So even if they're intraaxial lesions, they tend to exhibit pretty strong contrast enhancement. They can be associated with edema and mass effect. I would actually underline this, at least in my experience, meningeal enhancement is quite common with these. And interestingly, lymphoma likes to go to intracranial structures that are not primary brain parenchyma, but they really like the pituitary, they like the choroid plexus, and also cranial nerves. We are all having a tendency, I think, if we evaluate a brain MR to be very tunnel visioned. And so we always have to force ourselves to look at everything outside. Well, the skull is nearby, so is the musculature. So hopefully any lesions there will become apparent. But we should make an effort to look at all the structures included in the scan because, of course, involvement of lymph nodes and such is fairly common with lymphoma. There are very few discussions of what it does on CT, but based on the limited experience I have, it's very similar to what MR descriptions say. So they are very variable in their appearance. And this is one of the earlier cases that I've seen in my career. And I hope nobody can really see this because this was a case that goes back to 2000, dates me a little bit. So pre-contrast CT images on top, post-contrast CT images on the bottom. And you see that on the post-contrast images, there are multifocal, kind of variable size brain lesions. Some definitively look intraaxial, like this larger one here. This is very peripheral and it's touching the meningeal surface, but I would still suspect it's likely intraaxial as well. There are others, it looks like there's some leptomeningeal enhancement. There's midline shift indicating a mass effect towards the left. If you squint, you can make out the vasogenic edema. So even though this is CT, clearly a diagnosis of multifocal intracranial lesions was possible on this scan. This is a beautiful example of an MRI study courtesy of Dr. Danjou. This was a lab retriever with a 2-week history of ataxia, difficulty jumping. Pre-contrast images, T2 weighted flare on top at 2 different levels, and then T1 pre and post-contrast images on the bottom. This is a case that did have indeed enlargement of the pituitary gland, better seen, of course, on post-contrast images. So potentially could mimic other pituitary tumors, pituitary adenomas, carcinomas. However, there were other abnormalities, including marked meningeal enhancement along the ossis tentorium, both dorsally and ventrally, and also leptomeningeal enhancement with marked contrast enhancement extending into the sulci back here at the occipital lobe area. If you pay attention, and it's subtle, but you may also appreciate that there is some asymmetry to the bone marrow fat of the skull. Here at the level of the parietal lobe, temporal lobe area, you see that normal bone marrow fat should be T1 and T2 hyperintense, and that's the case on the left here, but on the right, you do appreciate that it is kind of more intermediate in intensity, and it's actually contrast enhancing. On post-contrast images, it's almost iso-intense to the fat again, while it's markedly darker on pre-contrast T1. So this is a case where bone marrow involvement is strongly suspected based on the MRI. This was, I think, the first MR case of intracranial lymphoma I ever saw confirmed. So I wanted to show this to you. It's not the prettiest study. It was a 1 Tesla magnet, but 5-year-old mastiff, 1 week history of progressive brainstem signs and progressing to stuporous state and coma. And these are just a few select post-contrast dorsal T1 weighted images with fat suppression. So with fat suppression, we accomplish that all the fat is suppressed and everything that we see bright is going to be contrast enhancing tissue. And this dog had multiple lesions. There was a large mass, intraaxial mass, associated with the right hemisphere, cerebral hemisphere, caudal to the right lateral ventricle, involving the occipital lobe here. That was the only true intracranial lesion we found, but it was very large. And then if you look outside the brain, you see abnormalities everywhere. There are multifocal muscle enhancing regions. Now, if this is truly all lymphoma, or if there could be some spasms or something, if this dog was, hitting his head, or maybe even some like seizures that were not really observed. However, there are some areas that look more mass-like here in the mesenteric musculature on the left. And then also it's an odd angle, but you see in the part of the skull, the caudal aspect of the zygomatic arch and the temporal bone here, there is marked patchy contrast enhancement within the bone marrow cavity. So bone involvement and also some contrast enhancing tissue in the nasal cavity and frontal sinus. Can't talk about lymphoma without mentioning cats. So I'm going to show you now a 14-year-old domestic shorthair cat with seizures and obtundation. This was a very interesting case because when we looked at the pre-contrast images, okay, sagittal T2, midline, honestly, not a ton to see, although in hindsight, there is something happening here in the dorsal aspect of the brain. There's also evidence of caudal shifting of the lamina quadrigemina here, indenting the cerebellum from rostrally. On transverse T2 and FLAIR images, it almost looked like it wanted to be a metabolic brain disease of some sort. A little bit of an odd age. Could it be a toxicity? Very symmetric, bilaterally symmetric hyperintensity to the white matter tracts of the forebrain. However, on post-contrast images, it became apparent that this is really just edema and nothing else, because there were two abnormalities. One was a large dorsal midline mass centered on the falx, which, at first glance might look purely extraaxial, like a meningioma would. However, if you squint, there are a couple of linear regions of enhancement extending into the brain parenchyma, so raising concern for a little bit of infiltration into brain parenchyma, or at least leptomeningeal extension. And then the pituitary gland was also judged to be mildly enlarged and rounded. This is a more recent example, 13-year-old female spayed domestic short-hair cat with abnormal mentation, various abnormalities there, tachypnea, ataxia. And this is a beautiful study because it was performed on a 3 Tesla magnet. Rachel Lampe from the University of Illinois sent me this case. And this cat had so many abnormalities, both extracranially and intracranially, as you can appreciate here. So there's marked edema along the white matter tracts of the left cerebral hemisphere, causing a midline shift. There is mass-like infiltration into the sinuses and subcutaneous tissues of the frontal sinus nasal cavity involvement. And on post-contrast images, massive thickening and contrast enhancement along the meninges, as well as infiltrating into brain parenchyma, meningeal enhancement extending further caudally, in this case, mostly pachymeningeal, so smooth along the brain surface, thickening contrast enhancement of the soft tissues of the head, bulla involvement. Now, if that's neoplasia or inflammation concurrent is a bit hard to tell. And then also really, really marked lymphadenopathy of the medial retropharyngeal and mandibular lymph nodes. One more cat that actually I wanted to share because it was a bit of a frustrating case, and I'd be curious if other people have similar frustrations. 12-year-old Havana cat that presented with actual nasal disease, 6 to 7 months nasal discharge dyspnea. And of course, we see nasal and nasopharyngeal lymphoma all the time. And because it was a nasal presentation, CT was performed rather than MRI. So there was a hypo-enhancing large mass in the nasopharynx with a bit of rim enhancement. The nasal cavity bilaterally contained variable amounts of mostly interestingly hypo-attenuating and hypo-enhancing material. But there was clearly intracranial enhancement. It was asymmetric, extending caudally from the cribriform plate all the way back to the midbrain. So we suspected lymphoma because nasopharyngeal mass, that is just what they do, with involvement of the sphenoid sinuses, which were completely filled with soft tissue material, and then extending into intracranial enhancement along the ventral aspect of the brain. Sadly, this was Guber on his postmortem, and lymphoma was confirmed. I'm going to show you the images here. And I'm not a pathologist, but this area here of the ventral forebrain and extending actually towards the pituitary gland doesn't grossly look normal to me. But again, I'm not a pathologist. And they diagnosed it with nasal lymphoma. Um, blah, blah, as per usual, immunohistochemistry we can do if you want to pay extra. But reason for the contrast, and they're talking about the intracranial contrast enhancement observed on CT is unclear. Lesions were essentially restricted to the nasal cavity, no evidence of neoplastic cells intracranially affecting the brain. However, we cannot rule out that the lesion extended into the cranial vault. That's exceedingly unhelpful. So I find sometimes that our findings on imaging and the findings on postmortem don't correlate too well. And I know postmortem is always the gold standard, but in this case, clearly there's something there. And why it was not confirmed is a little bit frustrating to me or beyond me. So lymphoma can be quite weird. As I already said, it likes to involve other structures intracranially, like the pituitary gland. And there is actually a paper talking about choroid plexus involvement with this disease, which is interesting. Now, in this case, it's a bit more straightforward because there are other abnormalities, like the marked enlargement of the pituitary gland, and involvement of both the choroid plexus of the fourth and the third ventricles. So this would probably not be mistaken for a choroid plexus tumor, a primary choroid plexus tumor. But one could imagine if it's just a choroid plexus nodule or mass, that could certainly be confused with choroid plexus papilloma or carcinoma. And then, and this is maybe a little bit beyond, it's not per se a primary CNS abnormality. It's a vascular anomaly, but it really predominantly affects the CNS, and that is intravascular lymphoma. So this is lymphoma of the vascular walls. these animals have a very different presentation from other animals with intracranial or spinal cord neoplasia in that they predominantly presents due to vascular accidents. So they have infarcts, often in the brain and or spinal cord, multiple episodes of infarcts over time until a diagnosis is made. Usually it's only possible on post-mortem. And on MR, there are very few like specific findings for this. However, what the paper proposes is that if you see this so-called vessel sign, where you have evidence on T2 star or even better susceptibility weighted imaging, clotted blood in vascular lumina, that this is somewhat more suggestive of intravascular lymphoma than other diseases, and concurrent enhancement of those lesions and also meningeal enhancement was quite common in this case series. So very interesting, different type of presentation with lymphoma. So moving on to histiocytic sarcoma, this is our next big tumor category. And there are a few papers and case series and reports of this. This is probably still the largest one, 19 cases in dogs. Retrievers and Pembroke Welsh Corgis are overrepresented. Everybody obviously always thinks of uh, retrievers and similar large breed dogs, but the Welsh Corgis is something to always keep on your radar. And this can involve the brain or spinal cord. And interestingly, in 4 of all those dogs, so it was 19 cases, in only 4 was this truly a disseminated histiocytic sarcoma, but it was limited to the CNS in 15 dogs, apparently. So that's interesting. So this is a round cell tumor, even though it's considered generally a disseminated disease process, can be very much limited to the CNS. Quite variable imaging findings, as we expect with round cell neoplasia. Extraaxial mass is predominated for the brain. Meningeal enhancement, often profound and remote from the primary mass. If anybody is interested, I know this is not per se imaging, but interestingly, pleocytosis was present in all dogs that had a CSF tap, and median survival time was very short, 3 days. So this is another study here, a bit more recent, and they've had very similar findings in that they again had retrievers and corgis predisposed. No surprise, we also saw a good number of Bernese Mountain Dogs and Rottweilers in their cohort, and interestingly also Shetland sheepdogs, which at least up to then were not really on my radar for getting histiocytic sarcoma, and again our corgis. In this, they had a little bit of a different distribution. So corgis and Shetland sheepdogs had predominantly primary tumors, so limited to the CNS, but Rotties had exclusively disseminated tumors. And then somewhat similar to the other study, CSF inflammation was common and characteristic of primary CNS histiocytic sarcoma. Neoplastic cells were actually found in the CSF of more than 50% of affected dogs. So that's also interesting because we often feel like, oh, it's tumor, we're probably not going to get anything on the CSF tap. Definitely worth a try if this is on your differential list. What about, since we're here to talk about imaging, MR findings? Poorly or well-defined single multifocal intraaxial or underlined extraaxial masses. Extraaxial masses appear to be way more common. Again, the usual variable intensity, typically iso to hypo on T1, hyper iso on T2, similar to lymphoma, moderate to strong contrast enhancement. Meningeal involvement is very common with this, also kind of similar to lymphoma, and that can manifest as actual true masses, thickening, contrast enhancement, or what we always think about with meningiomas, the dorsal tails are also reported with this. Concurrent edema and mass effect are quite common. So again, going to show you a few cases here, starting with Sally, 12-year-old female spayed mixed breed dog, acute onset of right forebrain and brainstem signs. This was the very first histiocytic sarcoma that I saw confirmed on MRI, at least that I recognized it. Predominant features on pre-contrast images were the marked vasogenic edema, mass effect, midline shift, subfalcine herniation. If you like, it really looks like the cingulate gyrus is making its way under the falx here. Um, Otherwise, really not too much to see on pre-contrast images, but what was very curious on post-contrast images was the marked and predominantly leptomeningeal enhancement with marked widening of the sulci. Very, very interesting appearance. And even though with meningeal enhancement, I think we have a tendency to always think inflammatory first, it can absolutely happen with certain neoplasms, and this is a tumor that really likes the meninges. Allie, 7-year-old mixed breed dog, grand mal seizure starting yesterday, had actually really amazingly advanced imaging abnormalities considering clinical signs just started. So we counted at least 3 masses, all peripheral, all kind of in the left cranial vault, all touching the meningeal surface, rather moderately enhancing. You see one here, and then 2 further caudally, kind of bilobed. These definitely look extra-axial. This might be a bit hard to tell, but I would probably suspect also extra-axial. Lots of vasogenic edema surrounding the lesion's mass effect, compression of the brainstem. You see the asymmetry of the caudal colliculi here. So very different appearance than the first case I showed you, but also confirmed as a histiocytic sarcoma. So these are all potentially extra-axial masses. Do we know how to distinguish histiocytic sarcomas from meningiomas? I'm sure there are cases where it's difficult, but there was a very nice paper a few years ago by Will May uh, out of Penn, who looked at inter-observer agreement and differentiation between histiocytic sarcoma and meningiomas in dogs. And what he found that histiocytic sarcomas tended to have more extensive edema. In both cases I showed you had really marked edema and more often had combined perilesional and distal meningeal enhancement of both pachy and leptomeningeals. What that means is you might have a mass in the rostral cranial vault and meningeal enhancement in the caudal fossa. That's not something you expect to see with meningiomas. And also, they often had extension into the sulci with the histiocytic sarcomas, very much like the first case I showed you, which is also not something meningiomas typically do. So meningiomas, on the other hand, tended to be more have perilesional edema focally and had more perilesional meningeal enhancement of the pachymeninges, which were thickened, forming the more classic dural tails. This slide I literally just added today. Histiocytic sarcoma in cats, never seen it. There's a single one case report that I could find with imaging. But of course, how it goes, a former neurology resident from our institution just went into practice this summer and was very proud, did this MRI a couple of weeks ago and said he was going to go to surgery on it if I would be interested in getting a copy of the case if once the histopath is back. And I was like, well, yeah, glanced at it. It was like, sure, another meningioma in a cat, have plenty of those, but fine. And it wasn't a meningioma, it was a histiocytic sarcoma. And I almost fell off my chair. I mean, lymphoma, okay, I could have been like, oh yeah. But no, this was histiocytic sarcoma. So now I've seen a case, not my own. And in hindsight, I'm kind of mad at myself for just blowing it off a little bit, should not have. It's obviously a large mass in the rostral fossa. There's extreme mass effect with this caudal transtentorial herniation, caudal shifting of the lamina quadrigemina, cerebellar herniation, edema of the cranial cervical spine, midline shift / subfalcine herniation. And the one thing, again, I wish I had paid a bit closer attention, was this little finger-like extension that seemed to be connecting into or diving into the brain parenchyma, which would be very unusual for just a meningioma. Anyway, now I've seen a histiocytic sarcoma in a cat and you have too, and hopefully you will not be as casual about extraaxial tumors in cats as I was in this case. Other tumor types, much less common, mast cell tumors, actually very poorly documented as far as I can tell in the veterinary literature as far as intracranial involvement is concerned. This is a nice one. This was a mast cell tumor infiltrating the sphenoid bone in an animal that presented with blindness. So not per se a brain lesion, but a cranial lesion. And I mean, any bone tumor conceivably could do this. But this was, to my knowledge, the only one that I could find. So it's never really been high on my differential list. This was then the first one that I remember seeing, and it really freaked me out a little bit. This was a dog that presented with seizures. We performed MRI. We saw this intracranial, strongly enhancing lesion, but there was also some nasal disease. So we speculated all these tumor types that can cross the cribriform plate, carcinoma. A lot of seem to be centered on the brain. So we're like, well, meningioma would be really weird, but some people think this can happen. And then we actually saw a few more, and my resident just recently did a little retrospective looking at cribriform plate lesions, and she found 4 cases of mast cell tumors crossing the cribriform. This was another one. This dog came in with nasal discharge and facial swelling. So, okay, it went to CT, not to MR, but clearly it had invaded into the cranial vault as well. So if you think about this, of course, the next step is always going to be biopsy, either blindly or endoscopically. If this thing degranulates while you're biopsying it, it's going to blow the brain right out of the foramen magnum. So I am like adequately freaked out because now I look at every plain nasal carcinoma CT that goes to the cribriform, and I wonder if we should just give Benadryl in case it's a mast cell tumor. So I wish I really could unsee these cases, and I can't. So we have 4 that we have collected now, and hopefully we'll be publishing those in a suitable timeline here. Malignant melanoma. This is actually something people seem to really love because there's this idea that, oh, melanoma on MR has a very characteristic appearance. I'm going to burst that bubble maybe a little bit. So this is the only case I've ever seen confirmed on CT, and there was nothing specific that this would be melanoma, but this dog had 2 separate strongly contrast enhancing lesions, one being intraaxial here, one most likely also being intraaxial, although it was very close to the choroid plexus. But strongly contrast enhancing metastases are outside the blood-brain barrier, and even if they're intraaxial, will have strong contrast enhancement, as we know. But otherwise, nothing really specific that this would be melanoma. So what about MRI? If you read textbook chapters, review articles, many of them will state, underlined with exclamation points, that melanoma metastasis may be T1 hyperintense and T2 hypointense due to the presence of melanin and maybe also hemorrhage in the lesions. That sounds great, right? That gives us some specificity. That's exciting. The first time that actually came to my attention more than other times was when this What's Your Diagnosis came out. Very nice What's Your Diagnosis by Sarah Pounder back then. Um, and it was not in the brain, it was in the salivary gland, interestingly. But yep, T1 hyperintense, T2 hypointense. And you read the discussion, it's like, yep, that's what melanomas do. So in my brain, it was like, yep, that's what melanomas do. So what is the evidence here? If you look at literature in people, they are pretty clear that melanoma metastases are kind of artificially divided into melanotic mets, and that's defined as having more than 10% melanotic cells on histopath, or amelanotic if they have less than 10%. So it's kind of a random number they picked. And only melanotic metastases, so only the ones that have more than 10% of melanotic cells, provide consistent and reliable hyperintensity on T1, hypointensity on T2. So Amelanotic metastases are completely nonspecific. Don't follow that rule. And on top of that, melanotic metastases are only accounting for about 25% of cerebral melanoma mets in people. So 75% of people have amelanotic brain metastasis, and these rules do not apply. So it's not a super helpful thing, really. So if you look at some images in people, this is what they say melanoma mets will look like. Lots of edema actually around this structure. I was surprised looking at this image how cavitary this thing looks, but clearly has a hypo-intense T2, hypo-intense rim, flare hypo-intense, and then a little bit of hyperintensity on the T1 along the periphery, not really screamingly, and then pretty strong ring enhancement here. What do we know about it in dogs? There's a very exciting paper um, until you actually read it as an imager. I'm sure it's still exciting for neurologists and pathologists. Um, Talking about metastatic melanoma of the CNS, retrospective analysis, comparative review, a very solid study, history of melanoma, full necropsy, including the brain, very high percentage of animals that had brain mets. So 38% of dogs included in the study, and they had more than 50 animals, and 38% of them had CNS metastasis. Oral cavity was the most common site of the primary melanoma. And then most common site of CNS mets was the cerebrum with smaller numbers, brainstem, cerebellum, or spinal cord. And seizures were the most common signs. Makes sense with forebrain localization. Not one MR image in this paper. Very disappointing, very sad. So anyway, great paper otherwise, just no imaging in it. So what do we know about melanoma mets then? This is out of May's textbook. This is one image shown. Yes, T2 hypointense, very marked susceptibility artifacts on T2 star, T1 hyperintense. And if you compare the pre and post contrast, T1 really doesn't seem to have a ton of enhancement. So I'm a bit worried that if I saw this case, I would probably go down the intracranial hemorrhage stroke route rather than melanoma route. But I guess there's always, follow up, additional information and so forth that you have to take into account. There's one paper describing melanoma mets to the meninges, just in case anybody has a case like this. Very subtly T2 hypointense linear regions in otherwise edematous or T2 hyperintense areas. Pretty strong contrast enhancement, mostly meningeal, mostly along the cingulate gyrus here. Otherwise, probably nothing too specific about this. And now I'm returning to the initial slide when I mentioned the transmissible venereal tumor. I always had it in here as, oh yeah, it doesn't go to the brain, doesn't go to the brain. I talked to a resident recently at another institution, and she says, oh yes, they do go there. And she sent me this paper, which in my defense had just come out this year, and it's not a journal I read as frequently as I should. But it can happen. These can metastasize to the brain. There are no MR or CT images in this paper, just post-mortem. And looking at these images, it looks like they can be quite variable, quite large, and also be in variable location, being what looks like thalamic here, forebrain here. So yeah, a little bit interesting. And I'm looking forward to the first imaging paper actually talking about these to see if there's anything specific. Okay, that brings us, and some of this will overlap, to round cell tumors of the spine. It's the same tumor type, so we will just run through a few more examples here. So as I already said, lymphoma can generally do whatever it wants. In dogs, it likes to do multifocal disease. It likes to actually involve the osseous vertebrae. Um, And what is fairly common, and that's also true in people, that it likes to involve more than one spinal compartment. So medullary cavity, vertebral canal, paraspinal soft tissues. It kind of likes to ooze through the cortical margins. It's called cortical sparing in people. Those are fairly common features with lymphoma in dogs. Oh, yeah, sorry. There it is. So vertebral changes may be confined just to the medullary cavity without evidence of lysis. In cats, the most common location of spinal lymphoma is actually extradural, which is a little bit different from what some older review articles have stated, or they can be both extra and intradural. If they're intradural, they may affect the leptomeninges and or the spinal cord, but it's really rare to have exclusively intradural location. So that's not a common presentation. Can be focal or multifocal. Spinal nerves may be involved, and that may be brachial plexus, lumbosacral plexus, other spinal nerves. So neurotropic form of lymphoma, quite common in cats. And of course, look at other organs because lymphoma can definitely multi-organ associated in cats. So a few examples here. This is a dog that presented with the cervical neurolocalization. On this T2 image on the top here, you see that the medullary cavity is mildly diffusely hyperintense compared to its neighbors, more obvious on the stir actually, where the fat in the adjacent vertebrae is suppressed. You also hopefully appreciate the nice cortical sparing where the cortical margins are maintained. And then on transverse images, you see that it has extended into the vertebral canal as well as the surrounding soft tissues. And in the vertebral canal, you do see a very nice bilobed distribution. There was a fairly recent paper earlier this year that I didn't actually include here, but that talked about this gull wing sign that we also see with hydrated disc extrusions. If you see it with a vertebral mass, it much prioritizes round cell neoplasia, including lymphoma, over sarcomas and carcinomas, just because of the sparing here of the meningovertebral ligament. This was another example in a dog. This dog had multifocal disease, multifocal T2 hyperintense lesions of vertebral bodies. And yes, we did do fat suppressed techniques as well to confirm that these were real and not just bone marrow disease. This dog also had lymphadenopathy and splenic abnormalities, and everything was aspirated as lymphoma subsequently. The cortical sparing can go to an extreme, and I've only seen 2 or 3 of these kind of cases ever definitively confirmed, a few more where we suspected this, but you see that you don't see much. Top image is a T2 weighted image. The nuclei are T2 hyperintense. Then we have a T1 weighted image. Then we have a stir and C, and then we have a post-contrast T1 weighted image with fat saturation at the bottom. And if you're not used to this magnet, you're likely, or these sequences on this magnet, you might not see any abnormalities. I know what to expect from our system, and I know that on the stir, I want the vertebrae to be black, like pitch black. They are darker than the surrounding musculature, so this was definitely abnormal. Every single vertebra was abnormal. This dog had diffuse bone marrow infiltration. Everything was also contrast enhancing compared to normal studies. And on bone marrow sampling, this dog was diagnosed with lymphoma. Can definitely happen, can probably happen with other bone marrow centric diseases too, but this was an example of confirmed lymphoma afterwards and just a very interesting presentation. This was just to complement this with a CT image as well in an older German Shepherd dog. Has had a diagnosis of lymphoma, was very painful in the hind end, and they weren't sure is it abdominal or musculoskeletal, so they chose CT over MRI, and we found this large lytic lesion largely sparing the cortical margins, but it had broken through the ventral aspect where there was a little bit of periosteal reaction to go with it. The diagnosis was made based on CT-guided sampling of the lesion to make sure there was nothing else going on. This is lymphoma in a cat. In cats, they do very similar things to dogs. Actually, it is a fairly common spinal tumor in cats. So on this sagittal T2 weighted image, you see that there's quite variable signal intensity of the vertebrae. It's unusual. Some of them being actually abnormally hypo-intense. That means that the normal bone marrow fat, which is hyperintense, has been replaced. The vertebrae on this sagittal stir here are kind of patchy, variable intensity. And you see that there's a focal region where the lesion has extended through pretty intact appearing cortex into the vertebral canal. There's also contrast enhancement in that area, resulting in spinal cord compression. There was a paper fairly recently, Durant et al., that talked about lymphoma in cats fairly commonly involving the nerves, as I said, and there's some very, very nice images. So brachial plexus tumors in cats, absolutely, you want to include lymphoma in your differential list because lymphoma can absolutely do this. It's not really commonly seen in dogs. I looked at a lot of our lumbar MR studies in retrospect, and we usually, unfortunately, do not include the whole pelvis and iliopsoas muscles with the associated femoral and sciatic nerves. But in this paper, they did, and they show the white arrowheads here delineating the femoral and sciatic nerves on the affected side compared to the normal side where they are much, much smaller. So make it a habit to look at that area if you're suspecting lymphoma in cats, because apparently it's actually quite common. Histiocytic sarcoma can also go to the spine and also has quite variable imaging findings. It is a round cell neoplasia, so it also likes to the bone marrow cavity, but it also likes to explode out and form large masses. It has a somewhat more aggressive behavior than some other round cell tumors. This is a dog that just had a solitary extradural mass. And then this dog here had multifocal, hyperintense and contrast enhancing lesions in vertebral bodies, some of them causing spinal cord compression. Going to show you an example here of a histiocytic sarcoma causing multifocal lesions. You see on the sagittal stir images, variable multiple vertebral bodies of the lumbar spine being T2 hyperintense. They're also T2 hyperintense, and this larger lesion has broken through the cortices into the vertebral canal, causing spinal cord compression at this level. Interestingly, in this case, this was a Labrador. We found organ abnormalities everywhere. As we said earlier, that's not true in all breeds, but make sure to look at all the structures included in your field. So there was a large right renal nodule. The spleen had really gnarly looking ring-like lesions, target-like lesions. The left kidney had a nodule in both the caudal and cranial pole. Don't think I have an image here. The liver, you see part of it here. The liver had multiple nodules as well. So this was truly the disseminated form of histiocytic sarcoma in this dog. As we mentioned earlier, histiocytic sarcoma really likes the meninges, especially the leptomeninges. And I've seen only a handful of these cases, but where it was actually limited to the meninges with no obvious masses, no obvious bone marrow involvement. This was the first one I've ever seen. And on the T2 weighted images, really not a whole lot to see. Oh, no, sorry, I'm lying. This is the post-contrast T1. So there was meningeal enhancement. The T2 had indeed been pretty unrewarding. What was frustrating was that our MR myelogram really looked like it wasn't working. There was complete suppression of the subarachnoid space. And we were just like, oh, the MR myelogram didn't work. Turns out it did work. There was just no CSF left because the meninges were so thickened, there was no CSF left. This is a transverse post-contrast image, so you see the strong contrast enhancement, how thick those meninges are. And this was the corresponding post-mortem image. So all the stuff that's brown here are neoplastic cells circumferentially infiltrating the meninges. This was a case of histiocytic sarcoma. Spinal mast cell tumors, there's only a small case series. It's rare, can be primary or metastatic. Imaging features quite variable and non-specific and overlap with both other round cell tumors and soft tissue tumors. These are a couple of images out of the paper. You see on the left here a nice extradural mass. It really could be anything. There's nothing specific about it. And then on the CT image from the paper, there was a large paraspinal mass invading into the vertebral canal through the intervertebral foramen here. Yeah, nothing specific about it. Very similar, annoyingly, to the cranial form we talked about. And this was another case that looked more like our typical round cell tumors with the bone marrow centricity in both the sacrum and the iliac wing. I've never had a case myself, but a neurologist friend of mine sent me a case from her practice, and this was a confirmed metastatic mast cell tumor that had previously been diagnosed, and then the dog became neurologic, severely painful, paraplegic. And you see on this MR study, T2 weighted images, stir images, and then post-contrast images down here, multifocal contrast enhancing bone marrow centric lesions, as well as involvement of the paraspinal soft tissues. The last larger tumor group for the spine that we need to talk is multiple myeloma. As you all well know, this requires evidence of at least 2 of 4 criteria. Monoclonal biclonal gammopathy, paraproteinemia, diagnostic imaging. If you look at the old textbooks of osteolytic bone lesions, a little peeve with that, 10 to 20% plasma cells in the bone marrow, and Bence-Jones proteinuria. I should have put a little asterisk here. This is still what's kind of commonly used in veterinary medicine. In people, they are revising these a little bit, so I think veterinary medicine is going to follow suit on that. But at least I think this is what most of us have probably learned at some point. So, yep, if it works, it works. This is a classic radiograph of a dog with multiple myeloma. Classically, they're all supposed to have these punched out lytic lesions, and you see them everywhere in this poor dog's spine, cervical spine, the atlas, and especially the axis here, lumbar spine, punched out lesions everywhere. But the osteolytic part, I take some offense in because this was a case that really stuck in my brain. This was a dog that came for MRI of the spine. We found that the T1 vertebra had hyperintensity, just completely confined to the medullary cavity. And this is the post-contrast image. We're like, well, this is weird. Let's go to CT and get a needle into it. And on CT, even knowing that it's there, this vertebra looks perfectly intact. He still had this lesion. We know it's there, but if we had just CT'd this dog, there's no lytic lesion visible even on CT. Radiographs, of course, would have shown even less. And a braver man than me drilled this needle into this vertebra and got plasma cell tumor out of it. So the solitary form of multiple myeloma. So I think the lytic bone lesions really, really needs to be rephrased to bone marrow centric lesions rather than true osteolysis, because of course it takes a while for those lytic lesions to develop. There is a paper that talks about MR findings with multiple myeloma. Quite variable, but multiple expensile. I don't know, I don't expect really expensile lesions personally, but they called them expensile, but they all were exhibiting the cortical sparing like we see with other round cell tumors. If they break through, of course, they can cause spinal cord compression. And this was interesting that the majority of lesions were hyper to iso-intense on T2 and T1, and variably, but usually strong homogeneous contrast enhancement. So the T1 and T2 hyperintensity is intriguing. And as I'm showing you here in this older standard schnauzer, it can be subtle, but it's real. And this dog had T1 and T2 hyperintense lesions in multiple vertebrae. Now, I think we often have a tendency to actually ignore those because bone marrow fat does the same thing. However, they stayed bright on the stir, on the fat suppressed techniques, so that ruled out fat, and they were contrast enhancing. So this really was consistent with multiple myeloma in this dog. I have one more multiple myeloma example because I can, 6-year-old tiger, and it's very typical. We see a lot of large cats, and the differentials are always cruciate rupture, hip luxation, or spinal cord injury. It was a spinal cord injury. And on these T2 weighted image on the left here, and the T1 weighted image on the right, you see these hyperintensities centered on the medullary cavity, and multiple myeloma was confirmed on necropsy in this cat. They were also contrast enhancing. So coming kind of towards the end here, how do we rank our differentials for extradural tumor? There was this kind of nice large study that were just looking at general imaging features and all tumor categories, and combined features that predicted round cell neoplasia in this paper were preservation of vertebral shape, so cortical sparing, more homogeneous contrast enhancement, and lesions centering on bone, versus mesenchymal neoplasia or sarcomas, resulting more commonly in altered vertebral shape, so explosions of the vertebrae, more heterogeneous enhancement, and lesions centering on soft tissues. And then, as I said earlier, there was a paper earlier this year that also talked about if you see this gull wing sign, paper by Monto et al., if you see a gull wing sign with spinal neoplasia, that also allows prioritization of some sort of round cell tumor over other tumor types, including mesenchymal tumors, because of sparing of the meningovertebral ligament. So summary and take-home messages. I find round cell tumors fascinating. They're weird. They may mimic other tumors. They may mimic benign lesions. So any Game of Thrones fans out there, you know nothing, Jon Snow. I feel we still have a ton to learn about round cell tumors. But I hope you found this interesting and somewhat educational. And hopefully you share my frustration with some of them and my fascination for others. And I really hope if you are hunting multiple myeloma, you're gonna start doing MR and not just survey radiographs. Thank you, and
Great.
I'm happy to address any questions you may have.
Yeah, great. Dr. Heck, thank you very much for that. That was fantastic. It's always lovely to see such well illustrated talks. All those images really, really helpful to drive those points home. So thanks for that. Yeah, we've got some questions for you. First one, in human medicine, lymphoma is described to have a marked diffusion restriction on MRI. Is there any information available about its diffusion restriction in dogs and cats?
It's actually a really excellent question. Yes, in people, they talk about that. I have not really looked into that scientifically. Our diffusion is at best questionable on our magnet, and I feel our image quality for brains, it's okay. For spines, it's terrible. On spines, we don't even try. So I think that would be a great research venue to look into and go back for people who routinely run good quality diffusion studies. To my knowledge, nobody has published that in animals. It's a really good question.
Okay, good stuff. Then another question regarding cats and spinal cord MRI. If you see a mixed distribution, do you tend to think directly more about lymphoma? So presumably by mixed, they're talking about maybe intramedullary, intradural, extradural.
Lymphoma certainly goes on my list, especially if there's bone involvement, and also especially if you find like other like abdominal organ abnormalities like lymph nodes. Having said that, I've been fooled by FIP more than I care to have been fooled by FIP because I feel there's so much overlap in FIP, in my experience, doesn't usually go to bone, but it likes the spinal cord, it likes the meninges. Um, and uh, if you're looking at just spinal cord and meningeal lesions, I would also now put feline MUE somewhere on my radar because it's never on my radar, but then occasionally you get post-mortem back and they're saying it was MUE or GME. And I was like, oh, yeah, that was not on my list because it's a cat. Now, if there's bone involvement, yeah, especially if it's multifocal, lymphoma goes high up on my list for cats.
Excellent. A couple more quick questions. I'm going to paraphrase this one. When is a choroid plexus not a choroid plexus? So presumably, when do you draw the line there between this is a prominent choroid plexus and this is
Mm.
something I should be concerned about being lymphoma? Is there anything that we can do?
Ooh, that's actually a good question. So I looked at with Rachel Lampe when she published that paper, we looked at a number of cases that had confirmed CNS lymphoma, and we had to kick out a few of them because they had a really hard time deciding, is this just a prominent choroid plexus or is this actually lymphoma infiltration? And the pathologists may or may not have actually cut into it. So we didn't have a definitive answer. I think that can be challenging. I if it's as massive as in that one example I showed you, yes, it's abnormal.
Yeah.
But if it's
Yeah.
just a little bit swollen, I struggle with that. I don't know.
Okay. Yeah. Um, this is good information from the top here. So this is this is good. Sometimes, like you said, with the diffusion weighted imaging, it's important for everyone to know what's not out there, what we don't know, what's difficult to answer. And then lastly, then is there any benefit in follow-up MRIs with some of these tumors if you've attempted to treat them? Does some appear in a different manner after a period of time? Does some more likely to disappear, I suppose?
Yeah, it's another excellent question. We, unfortunately, at our institution, very rarely do any kind of recheck MRIs, especially if the animals are doing well. um, because it's hard to sell it to the client. You
Yeah,
need another
yeah,
anesthesia episode. I would expect if it's lymphoma and they're doing better, it probably has at least improved, if not resolved. Does it ever fully go away? I have that same frustration with FIP and FIP treatments. Like, how much does it ever completely go
yeah.
away?
Mm.
Does it? Um, so unfortunately, no first-hand information. We don't routinely reimage animals if they do well, sadly.
Okay, yeah, we need to be encouraging insurance across the board so that people
Yeah.
can come in and do
Yeah,
all of these
exactly.
follow-ups, help us out with understanding
I-
what to expect.
Yeah, yeah,
All right.
exactly. It
Well,
would be
thank you.
super interesting.
Yeah, yeah, I know.
Yeah.
Well, thank you so much for that really thorough review of the topic. That was extremely helpful, and it's something that's difficult to kind of piece all of that information together in a sort of up-to-date fashion. So thanks to that. Thanks to you for that. Thanks also to Hallmark for sponsoring this webinar series. Join us on in the next session on December the 4th, when Dr. Brian Torres will be giving us an update on the imaging of canine sports injuries. So thank you for attending and goodbye until then.
Thank you. Bye.
Bye bye.